Okay, I have 7:30 Eastern time. Let's go ahead and get started. Welcome to the SADS Foundation's 12th webinar in our Living with SADS series. Tonight on implantable cardiac devices and leads, I'm Marcia Baker. I'm the program director for the SADS Foundation. Thank you for joining us tonight. A few reminders before we begin the webinar. Please keep your audio muted during the presentation to improve sound quality for all. You have the option to turn on your video camera or not. That's totally up to you. We love to see your faces. Following the presentations, we have plenty of time for questions and answers. You may type your question in the chat field anytime during the presentations, and we will address the questions at the end. This webinar is being recorded, and it may be viewed later on the SADS YouTube channel. Now I'd like to introduce our two speakers. Both are international experts in the field of device management for cardiac arrhythmias. Dr. Charles Berul is Chief of Cardiology, a pediatric electrophysiologist, and co-director of the Children's National Heart Institute at Children's National Hospital. He holds the Van Meter Company's professorship in cardiology in Washington, D.C. Dr. Charles Love is the director of the Johns Hopkins Cardiac Rhythm Device Services and professor of medicine in the Division of Cardiology and adult electrophysiologist in Baltimore. Dr. Love has implanted more than 9,000 devices and removed over 2,000 ICD wires. The SADS Foundation is grateful to receive an educational grant from Philips to help support this webinar. It's my pleasure to welcome both Dr. Berul and Dr. Love. They're both volunteering their expertise and knowledge with us tonight and are not being compensated. Now I'd like to turn over the program to Dr. Berul to begin.
Well, thanks so much, Marcia, and I appreciate the SADS Foundation for inviting us to speak. I'm going to talk a little bit about what's new in ICDs, is what I was tasked to talk with. And due to the pandemic over the past year, even though Dr. Love and I live and work about 30 miles apart, we still haven't seen each other. So it's nice to see you, even if it's virtually. And since I'm a pediatric electrophysiologist, I'm going to focus a little bit on some of the unique aspects of putting in defibrillators in children. I'm going to leave the part about leads mostly to Dr. Love. And as we all know, children are not just small adults. It's not only that their size is different, but they often have the concomitant presence of congenital heart disease. They may have some venous abnormalities and other issues that make them different from adults. And most of the devices that we use are not specifically designed for children. And so we have to modify devices such as this ICD and this little ballerina. We have to modify adult-sized devices to be placed in children. And often that requires a bigger procedure, such as a sternotomy or thoracotomy, to place the device in the child. Now, ICDs have come a long way. I was given this nice plaque by a company when I put in an ICD, and at that time, in 1994, so 26 plus years ago, at that point, she was the youngest recipient of an ICD. And it was huge compared to her size. She was just about 10 years old, a small 10-year-old. Now we put ICDs in much smaller patients, but at that time, she was the smallest patient, and she had trouble sitting up because it was so big in her belly. Now, the X-ray next to the plaque is not that child, but is an infant who has both a pacemaker and an ICD in the abdominal area, and a lot of space junk, a lot of leads and abandoned wires in and on the heart. So what's new that's good for pediatrics? And I'm going to, again, focus on generators. The devices haven't gotten much smaller. They've gotten a little bit smaller, but not that much smaller compared to progress in other technologies. Miniaturization is feasible, but there's really no market incentive for pediatrics because we're talking about hundreds, not hundreds of thousands of children who need ICDs every year. Now, children require lower defibrillation energy, so you could pack less joules into a smaller device. The battery and capacitor technology is improving, and so it's reasonable to come up with a miniaturized pediatric ICD. Now, Dr. Love's going to talk about the weakest link, which is the leads, which seem to have a much higher failure rate than the generators and have more challenges in taking them out. I'm going to talk about some of the newer things. Now, this is not so new. In fact, these x-rays are from 20 years ago when we first reported the first baby to undergo a subcutaneous ICD. This was before the commercially available one was out. And we reported this using available devices and technology. And with the same concept of an AED, an external defibrillator, where you take the patches and put them on the skin, we took an array and put it just under the skin in the left chest wall and the generator in the belly. And in the same year, 2 different papers from Europe came out describing a similar thing, as you can see on the right side of the screen, similar technology. And this has been now reported for hundreds of children over the past 20 years with intermediate term results. There's other ways that we can put in devices without having to do a full sternotomy or thoracotomy, and apologize for those of you who are eating dinner while you're watching this webinar. But you can see using videoscopic ports that you can get good visualization, and you don't need a big sternotomy or thoracotomy, with less morbidity and faster recovery. And as you can see from these pictures of a defibrillator lead on the left and a pacing lead on the right, you can get very good visibility and see where the critical structures of the heart are, so you don't injure those as you put them in and around the heart. So there's really 4 different routes for ICD placement in children. There's the transvenous route. I'm not sure if you can see my arrow, but I'm just going to use it. The transvenous route. And in this picture, you see some extra slack left on the transvenous lead to allow for patient growth as the child grows up. The epicardial patches, which are almost obsolete these days because they tended to crinkle and crack as children grew and became non-functional. The subcutaneous array or coil, like we just talked about, and putting a lead that's made for transvenous use into the posterior pericardial space or behind the heart for use in the smallest of infants. Now, the subcutaneous ICD came out about 10 years ago and was very exciting because there'd be no wires in the venous system. And that seemed like a great idea, so that you wouldn't have to deal with the extraction issues that Dr. Love's going to talk about in a few minutes. The generator goes in the left underarm and the lead goes under the skin. Here's one of the earliest ones put in a child. This is a 10-year-old little boy with hypertrophic cardiomyopathy. He weighs about 32 kilograms. And this is what it looks like post-implant. It's a pretty bulky device for a small, skinny kid. And you can see cosmetically, it's good, but not great. After he had a device in, he is playing a video game with his brother, complaining of dizziness, loss of hearing, and chest pain. And what we see as the electrophysiologist is about 26 seconds later, he gets an appropriate shock from his ICD back into sinus rhythm, a potentially life-saving shock for ventricular fibrillation. So these are great devices. There is a second version that is new and improved and a bit smaller. It's a little bit thinner. It's a little bit less heavy, and it lasts longer. And so there are some significant advantages in version 2 versus version 1, which is good for children, but it's still pretty big. And relative to a child's chest size, we often have to put it below the muscle rather than subcutaneous. So there's still some discomfort in putting these big devices in. So they're not perfect yet. And it requires some customization. In this paper that came out from France, here's 2 examples on the left where they have to custom bend or bow the coil because the child is too small compared to the length of the coil, and they don't make different sizes. And so you have to bend the coil to fit it in the smaller chest. And on the right side, no, the x-ray is not reversed. This is a child with dextrocardia or a right-sided heart. And so they had to put the subcutaneous ICD on the right underarm because the heart's on the right side of the chest. And there's big concerns really about sensing. The devices have difficulty both sensing too much and sensing too little. On the top, this is a child with SVT, supraventricular tachycardia, not a life-threatening condition, but a fast heart rate from the top part of the heart. And the kid gets shocked because the device thinks it's ventricular tachycardia. And on the bottom, even worse, it's double counting. It's counting both the normal heartbeat and then the T wave following it, or what we call T wave over sensing. And so it's counting the rate at twice what the true heart rate is. And for someone who's just sitting there minding their own business and get a somewhat uncomfortable shock, that can be annoying and can be also sometimes dangerous. And importantly, these subcutaneous ICDs, unlike the regular ICDs, transvenous ICDs, they don't have pacing capability. And so patients with bradycardia or low heart rate, the device is not going to be able to pace them. And here's an unfortunate example of a child with an ICD who has asystole and doesn't get paced. So sometimes in pediatrics, you have to be creative, and we have to customize these devices to make them appropriate for use in children with inherited arrhythmia conditions. So I'm going to give you a 5-minute story on what I've been doing for probably 20 years, and we're going to condense it into 5 minutes. And that's trying to develop a minimally invasive percutaneous ICD, meaning it going through a needle or a sheath, rather than the picture on the left, this picture of an open chest sternotomy or thoracotomy. It's a lot of surgery for the surgeon to just have to put a couple of stitches on the lead to sew it on the outside of the heart. And so what we've been trying to do is develop this percutaneous model where you just put a small needle or sheath in to be able to place the lead. And this is the current version of what we're doing. It's a little port with 2 channels. This is in a piglet model. That's why there's 8 nipples and not 2. The lead goes through a small port, just less than a centimeter, just under the rib cage, in this what we call the subxiphoid region. And through that port, we can put both a needle and a camera side by side. And so the camera can watch the needle, as you see here, going into the pericardial space, the lining of the heart. The needle goes in there, and then a wire goes through the needle. And then we pull the sharp part out, and it's just a wire. And over the wire goes a plastic sheath to allow access to the heart. Once the sheath is in, we can put an ICD lead through the sheath and fixate it, attach it to the outside of the heart, the epicardium, and then take the sheath away. And you can see the coronary arteries and all of the areas that you don't want to attach. And so because of the excellent visualization of the camera, and then there's just a small hole in the pericardium, and that's the whole procedure, putting in the ICD lead percutaneously through a wire. That's what we've been developing. We're pretty close, but we haven't yet started putting it in children. These are still animal studies, but I wanted to give you an early look at our progress and trying to make a better ICD. For those of you who are old enough to remember The Bionic Man, that was one of my favorite shows from the 1970s. And the next generation ICD is sort of like The Bionic Man. They called him the $6 million man because of all his new parts that they had to implant in him to make him, as they called him, bionic. And the new ICDs have to be smaller, flatter, smarter, and longer lasting. And that's pretty feasible to come up with a miniaturization, whether it's something small and flat, like the size of a quarter that's attached to a lead, or some other computer-assisted design to come up with a percutaneous lead or needle-driven lead. That is what our aim is. And as I said earlier, electrophysiologists must be creative. And there's a lot of skeptics out there. They think it can't be done. You think about it, my slide advances, if you think about it, this is how TV was watched in the 1960s. These are the giant TV consoles that we watched in black and white. And nowadays, this is how we're watching TV on our phones. Brilliant HD color, tiny, flat, smaller, faster, and smarter. So it's not unreasonable to think that we can go from what this ICD looked like in 1990, not that long ago. This is an ICD from 1990. It's very reasonable to think that we can deliver a port-driven percutaneous ICD that's the size of that little device that you see compared to the penny, And my ultimate goal is to be able to deliver this in neonates and even fetuses before they're born for protection. And it's important to realize that ICDs work. We talk about all the problems with ICDs, and they're too big and they break and they have lead fractures. But for the vast majority of people, these are life-saving devices, and they're really important to have these technologies as we continue to improve upon them. I look forward to your questions. Thank you very much. I'm going to stop sharing and pass it off to Dr. Love.
Thank you, Dr. Berul.
Thanks, John. Okay, there we go. So it's a pleasure to be here, and I really enjoy speaking to patients and families that have defibrillators. And many of you probably know more about defibrillators than most general physicians know about defibrillators, and maybe some regular cardiologists. But so I'd like to start off a little bit to talk quickly about understanding your ICD, and then really go into this issue of dealing with failures and infections with ICDs. So first of all, I'm from Johns Hopkins, and one of the questions that I get a lot is, who is Johns Hopkins? It's not John Hopkins, it's Johns Hopkins. Well, he was a Quaker businessman that died in 1873, and he left $10 million, which is a lot of money today. It's a bucket load back in 1873 to start a medical school and university. And the way he got the name was his first name was inherited from his grandfather, who was Johns Hopkins, who got his first name when his mother, Margaret Johns, married Gerard Hopkins. So that's where the name Johns comes from. It's actually the last name of his great-grandmother. That's why I wrote Johns Hopkins. So most of you are probably aware there's two main arrhythmias that we're concerned about with why you got a defibrillator. You've got one, and why your family member got one. The first is ventricular tachycardia, which is doctors speak for real fast heart rhythms coming from the body chamber of the heart. And this is what that looks like if you haven't seen it. We can see that there's like a regular beat here, and this funny looking one here, which we call PVC. And then we get a couple of normal ones. Then we have this real fast rhythm here. This is going about 300 beats per minute. If you were to be awake with this, you would probably feel some palpitations, probably lightheaded, dizzy. You wouldn't do real well. And we'd like to get rid of this because this can either degenerate into something called ventricular fibrillation, or ventricular fibrillation can be a primary rhythm. And this is what ventricular fibrillation looks like. And if it looks to you like a bunch of noise, it is. The heart is just quivering. And if it's quivering, it's not squeezing at all. It's not pumping any blood. In fact, it's described in the medical texts. And actually, I felt a fibrillating heart. It's described as feeling a bag of worms. It just is this kind of wishy, squeezy thing. It's not doing any effect at all. So you've got about 3 minutes until brain damage starts to set in, and about 10 minutes until you're irreversibly gone. So without defibrillation, to cure ventricular fibrillation, the end is near, so to speak. And the incidence of sudden cardiac death is not small. It's actually the most common cause of death in the United States. Many of you probably have conditions that put you at very high risk for it. The general population is at low risk, but there's so many people in the general population that even though the incidence is small, there's a lot of people that die of sudden cardiac death. Fortunately, people that have diagnoses such as the kinds of things I'm sure many of you have, they will die at a much higher rate for your diagnosis, if you understand what I'm saying, as opposed to people without a cardiac diagnosis. Maybe they will die at 0.01% of sudden cardiac death, but there's so many of those people who ends up being a lot of sudden cardiac death. Now, the problem is only about 2 to 15% of these people reach the hospital. If you're lucky enough to live in a city like Seattle, they've got one of the best emergency medical responses in the country, and they do pretty well. If you're not in Seattle, then maybe you are a little more out of luck. And only half of those who survive, or half of those who survive the sudden cardiac death, actually survive to discharge from the hospital. And many people have brain damage and things like that. So really, it's not so great. So why is there such poor survival? Well, someone has to see you collapse. And what happens if you're sleeping? Well, you wake up dead, so to speak. What if you're alone? Nobody around. And what if you're, like when I lived in Manhattan, I would sit there and watch this gridlock And the ambulances would sit in this traffic with the lights and sirens blaring, and there was nowhere to go. So you're cold and stiff by the time that the EMS gets to you. So somebody's got to start CPR. And I'm assuming all of you know CPR and all of your loved ones know CPR. And if you don't, you should learn. Someone has to call 911 and find an automated external defibrillator and get you defibrillated. And it has to be delivered soon. And even to survive, maybe brain damage. So what does your device do? Well, if you have a pacemaker, that just keeps your heart from going too slow. It can't slow down fast rhythms by and large. But an implantable cardioverter defibrillator, ICD, can shock the heart, just like you use the paddles, or it uses a burst of very fast pacing pulses to terminate fast and potentially leave the heart rhythms. And as Charlie just showed you, there's been a lot of improvements. On the right, you see a regular pacemaker, which is pretty small, sitting on the ends of the fingers, and a current generation ICD on the left, which is significantly larger, but much, much smaller than the ones we used to put in. The ones we used to put in, like the one on the left there, is about like 3 by 4.5 inches and almost an inch thick. The newer ones are so much smaller and lighter and more, all smarter, a lot more brains inside. So we're getting to these very small things like Charlie was talking about, but we're not quite as small as I think our folks would like them to be. So most ICDs are also pacemakers. Again, pacemakers are not ICDs. One exception, as was just talked about, is that subcutaneous ICD with the wire outside of the heart, generally those can't pace the heart. Some rare exceptions, but generally they can not pace. Pacemakers are not ICDs. They can't shock. They can't overdrive pace the ventricle. And implantable loop recorders don't deliver any therapy. What they're able to do is record things, but they don't actually do anything. So you need an ICD. Here's a cartoon of which you probably have implanted or what one has implanted. Typically, it sits up in the upper chest, usually left side if you're right-handed, right side if you're left-handed. And the wires go through a vein down to your heart, one to the right ventricle, one, if you have more than one, you probably have a second one in the right atrium, and some people even have another one reaching around to the left ventricle to create more synchrony between the right and left ventricles. That happens for certain kinds of heart disorders we call cardiomyopathy. So that's how that transvenous one works. The subcutaneous one, as you've already seen this, there's a wire that sits outside of the chest wall. It's under the skin and next to the sternum. And then the device that's over here, and the shock is delivered between the coil next to the sternum and the big device that sits under the left arm. So what can go wrong? Well, of course, your battery will deplete, and that's going to happen over time. And generally, we replace the entire device, not the wires. Remember, the battery is part of the device. It's welded inside. A lot of people think you just change the battery. You actually change the whole device. Wires and leads can fail. Insulation can be disrupted. Conductor coils can fracture. Think of a coat hanger that bends and flexes over and over again. Sooner or later, it will probably break. And a conductor coil sits on the collarbone. Every time you move your arm up and down, it moves. Your heart beats 40 million times a year. It's an incredible amount of stress on a wire. So wires can break. And infection can occur either in the pocket or much worse in the blood or inside the heart around the wires. Recently, I'll bet everybody that has been that's watching this, if you've got a device, you've probably heard about an alert or recall. Every company's had an issue with a premature battery depletion issue. But that occurs in a small number of patients, but it still can occur. So very importantly, even though it's uncommon, stay connected. Remote monitoring is vital for all of your devices. Keep connected to it. So here's what a wire fracture looks like. This is a pacemaker wire, and you can see right under the collarbone here, there's a disruption of the wire. And this is a pacemaker, but this can cause discontinuity and, of course, malfunction of the system. We saw one looking like this as well. Charlie showed a very similar picture with insulation has failed and these conductive coils have eroded through the insulation. And this can create noise and, again, failure of the wire. The wire fails, it can fail pace, it can fail the sense and shock of that rhythm, and maybe almost as bad, the noise that is created by a failed wire can create electrical noise that the device sees, thinks you're in a bad rhythm, and then shock one unnecessarily, sometimes many, many times. create a lot of issues. So if your device begins to beep or vibrate, contact your device clinic right away. If no, don't wait about that. And again, stay connected. If you don't have remote monitoring, get it. If you have it, make sure you're always connected, because when the device does its daily check, it sees that problem, it's going to let the clinic know. What if you just cap off non-functional wires and place a new one? Well, then you can kind of get into what I call linguini of the central circulation. You really need a little marinara sauce here, and you got yourself a nice meal. This patient is just got multiple wires in, and this creates a lot of problem for the patient as time goes on. It creates a lot of problem for us as need management experts. So when you put in these wires and leave them behind, there's an increased risk of infection at 5 years. And if you do get infected, the more wires you have in, and the longer they're in, the more difficult they are to take out, and the higher the risk of taking them out. You're 5 times more likely to need tools where you grab them from the femoral or the vein in the leg. You're 4 times more likely to leave bits and pieces behind, and you're 2.5 or so more times likely to have a major adverse event, which is not a good thing to do in surgery. So what about infection? Infection is something that unfortunately many patients end up dealing with. You can see redness at the site. You can see swelling at the site. There can be an opening leading to the device itself, and there can be pus from the pocket. Here's an example of just a little stitch abscess here. This incision is healing pretty well, but there's just a little stitch abscess. So we don't get too crazy about this. This you can pluck out with a tweezer. You can use some oral antibiotics if necessary and get any cellulitis cleared up. Not a big problem. However, this is another device, and you can see this swelling that's occurring around the device. If this has occurred immediately after the operation, say 24 hours or so after the operation, most likely this is what we call a hematoma. It's a collection of blood, not such a big deal. Usually it just goes away, creates some pretty colors for a while, and then it's get all absorbed, not a problem. But as time goes on, this is a pretty well-healed incision now. So this is not a fresh implant. This has become absorbed, and it's unlikely that pocket is full of pus. This is how they can present. Doesn't necessarily look real bad. This is things that we short. Here's a situation where we have a well-healed incision, but we have this little hole here. We have this drainage coming out here. Again, pus is always a very bad thing when you're dealing with pus therapy. Another example of a wire that's eroded through the skin, a little bit of pus here. We actually had a patient that had a wire eroded through the skin, and when the patient took their shirt off, they actually had hung their sunglasses, put one of their earpieces through here, and actually had their sunglasses hanging through the loop, because this is completely healed underneath the loop. And they thought that was pretty cool to have a place to hang their sunglasses, but we didn't think it was so interesting. And here's a device that is truly eroding through the skin, no question. And then you always get the patient that comes in and says, yeah, doc, everything's just fine with my device. And you take a look at it, and they kind of come in looking like this. Clearly not the way things ought to be looking. So we see all kinds of different presentations of patients in the device clinic. Systemic infections are actually more serious than these very obvious infections underneath the skin. They can present with fevers, chills, elevated white blood cell counts, positive blood cultures, and vegetations on an echocardiogram. And I don't know how well this will show up over Zoom, but this big golf ball sitting inside this is the pumping chamber of the heart, the right ventricle. This big golf ball is actually a vegetation that is encased around a pacemaker wire. You get a little flash of the wire coming through here. And this is a bunch of bacteria that have set up shop and created a large mass around the pacemaker wire. And this can be a lethal situation. A lot of patients are not diagnosed appropriately. They don't get their infections diagnosed. They show up with fever or chills. Somebody thinks they have influenza, anything going on. But about 41% of infected device patients have a pocket that looks like this. It looks perfect. It looks completely healed. And most of these infections occur about a year or so after the last pocket manipulation. If you've had a device change, then you are at a higher risk for pocket infection. Each time we go into that pocket, the risk of infection goes up and up and up. And many systemic infections have a source other than the device. Maybe you've had a urinary tract infection, or you have a septic joint, or you've had pneumonia or something of that nature. That can seed the device pocket or the device lead. The overall rate of ICD infection is about 6% at 15 years. That's not a small number. Many of you will have devices for many more years than that. And said we got it for 25 years, it can be high as 11 or 12%. And every time you go into that pocket, the risk of that infection goes up and up. So what are the outcomes? Well, a lot of people are afraid of getting an extraction. They're being told that the risk of dying from the extraction is 5%. Crazy numbers like that. Well, actually, the risk of mortality from extraction in good hands is less than 0.3%. And this is actually older data before we had what we call rescue balloon or bridge balloon that has cut that rate in half. So the risk of dying from lead extraction in good hands is actually quite small. But if you have a infection of your cardiac implantable electronic device, CIED, that's your ICD, your pacemaker, and you don't deal with that with extraction, the mortality rate is around 25 to 35%. And if you have the infection inside your bloodstream, that mortality rate can get up to about 2/3 to 66%. So if we have what we call bacteremia, that's blood bacteria in your blood, or endocarditis, that's the infection inside your heart. If you treat with antibiotics only, the mortality rate is very, very high. And the relapse rate, once you stop the antibiotics, is actually close to 100%. On the other hand, if you do an extraction early, you can get those mortality rates down quite a bit, and the relapse rate is close to 0. And again, when you look at the procedural risk, the risk of us doing something bad to you in the operation, it's very low compared to the risk of dying if you don't treat the infection aggressively. So if you do need an extraction, it's important that you find an expert. Multiple studies have shown that if you go to a low volume center, where physicians and the staff don't do many extractions, they'll have a higher procedural failure rate, a higher clinical failure rate, which means not only don't they get all of the wire out, but they don't really get the job done that they came to get done. They don't really clear out the infection. And they have significantly higher major adverse event rates, 2.8, almost 2.9%, versus high volume centers where they see about 0.8%. So what can go wrong? Well, you can do some bad things. And if that happens, we have to get to the operating room. Actually, we do this in a special operating room, a hybrid lab. We have to have a surgeon open the chest emergently to perform a rescue in those circumstances. But in the vast majority of cases now, we're able to fix the hole and have the patient leave the hospital in good condition with a cure of whatever else is going on in need. So the core principle that you have to go home with here tonight, or stay at home with tonight, if you're watching this, is if your device is infected, or if you have bacteria growing out of your blood, you should have the pacemaker or ICD removed. There are some rare exceptions to that, like I said, superficial cellulitis, and there's some other bacteremias that we think we can cure with antibiotics. But if you are ever diagnosed with staphylococcus in the bloodstream, you should be looking for someone to be removing that system. Infection equals extraction. Antibiotics alone will not work if you have anything more than local skin cellulitis, again, with a few exceptions. Again, if you don't take it out, your survival rate is going to be much lower than if you take it out. Pocket infections, again, even if you don't take the device out and get it cleared up, the mortality rate will be significantly lower. So very quickly, how do we go about doing it? Well, this is Dr. Love doing a lead extraction. Actually, the way they used to do it. Nowadays, we use a sheath over the wire. So this is a tube placed over the wire, and we use that to work our way down over the wire because the wire goes into the vein, into the heart. There's all sorts of things that attach onto it. This is a picture of a laser going over a wire that's inside an animated heart. That's some work I did at the University of Minnesota. And that's what it looks like inside the heart. But actually, go and look at it, that laser is pulsing and going through the tissues there. So in conclusion, infection equals system removal. Extraction of leads is safe and effective, much safer than leaving things behind. The risk of removing leads should be weighed against the risk of leaving them behind. If I have a 90-year-old person who has one wire that's broken, I'm not going to extract that wire by and large. I'm just going to give them a new one. But a younger person who's going to have multiple leads in their lifetime, we don't want them to end up looking like that X-ray I showed you early on with 9 or 10 leads and stuff. And if you do need an extraction, find a physician that does a lot of them and has a good track. So at that point, I'm going to stop sharing my screen here, and thank you all for being here tonight.
Well, thank you very much, Dr. Love, and thank you, Dr. Berul. And we already have some questions coming in the chat box. So let's get started. I'll just take these in the order in which they've come in. Dr. Berul, how far off do you think the med tech companies are from having a smaller ICD?
Yeah, I think that the companies are all continuing to make smaller and smaller ICDs, as we both showed. But in terms of the sort of miniaturized tiny one that I was showing, I think that's still a ways off. And the challenge is going to be the market argument. In other words, there's not enough patients to have investors in a company or shareholders or board of directors say, okay, this is a good business investment. And so I think it's going to take philanthropy, maybe some angel investors to get that done with a smaller company rather than one of the big 3 or 4 device companies.
So for either one of you, would you be able to address the safety of technology breaches for ICD data?
So I think that may be referring to information breaches as opposed to technology breaches. So I'll address that unless there's something else going on with that question. All of these devices, when you talk about remote monitoring, they're highly secure. There's this handshake that goes on between the remote monitor or your cell phone in this case. It will only talk to a device that matches the correct serial number that it's programmed to talk to. All of the data is encrypted going back and forth. And there have been early on, there's a theoretical ability to hack into a device, but that was actually never done outside of that.
Except for that Homeland episode about 3 or 4 years ago.
Exactly.
Every electrophysiologist got hundreds of calls after that episode of Homeland.
With the exception that the transmitter was actually plugged into anything. It's truly impossible to do. It's on that episode. It was a crazy one. There's a couple other goofy ones out there too, but by and large, it's a very secure system. Nothing's impossible to hack, but it is extremely the data are also stored on encrypted servers, and it's very limited as to who can see that data. In fact, if Charlie has a patient and I want to view their data, if they come to see me as a consult, I want to log into the CareLink or Merlin, the Latitude website, or home monitoring websites. If I want to log in and see his patient, I can't do that. He has to log in and send it to me. That's the only way that happens. He has to release the patient, and the patient has to enroll with me. They're really trying to make it very, very secure.
Very good, thank you. So Randy had his ICD implanted in November of 2019, and he asked if he needs to be concerned about static electricity.
You want to hit that one, Charlie?
I don't think so. And there's lots of used to be a lot more environmental influences on ICDs that could cause inappropriate shocks. And the one everybody talked about was microwaves. But any kind of external electricity has not been an issue anymore. There's adequate filters. People worried about cell phones, and there are some small magnets that need to be careful of. But the real issues were MRIs, which now most devices are MRI conditional, and large industrial magnets. But other things, I think static electricity and microwaves, you don't have to worry about so much.
Let me chime in on that just a bit too. So I agree entirely. I always tell patients, as long as you don't put the pacemaker or defibrillator in the microwave oven, they'll be fine. Most patients won't fit it.
I tell them don't put the baby
some
in.
years well, but not fine. The other thing that's actually become a little bit of an issue now that it's got into the lay literature and the press is the issue of the iPhone 12s. The back of the iPhone 12, and you can see I have a regular iPhone here. The back side of an iPhone 12 is designed to charge wirelessly. So you just put on a mat, or actually it's got a little gizmo that snaps onto it. And that little gizmo's got, at the back of the phone actually has two relatively powerful magnets in it, as does the iPhone watch. And if you place that directly over your device, it is possible for it to activate what we call magnet mode. And in a defibrillator, magnet mode just tells the device not to deliver a shock if you go into a bad room. So we recommend actually if you've got one of these new phones, it's got the magnetic coupler on the back, that you not put it in your shirt pocket directly over your device. Other than that, it's probably just fine to put a phone. That's actually something that's just come to light in the last 7 months.
Yes, and the SADS Foundation sent out a notice about that several weeks ago. So thank you for adding that. Dr. Love, have you seen any instances of metal allergies developing due to abandoned leads?
Well, that's a really interesting question. Leads are very inert generally. There are different alloys that are used in the conductive plates. The insulation is generally polyurethane or silicon rubber that are very, very biodegradable. But when those break down, some of the alloys may contain nickel. And nickel can cause allergies in some people. There are rare allergies to device cans. Most of the cans nowadays are made out of titanium, which are very inert, very hypoallergenic. But there are rare people who are allergic to titanium, as well as some of the other components of the device, the epoxy of the top of the device, that's silicon rubber, grommets, the rarely the wires. So and we actually can do some allergy testing for these patients. Some of the device companies have little allergy kits that we can put little injections into the skin to see if they react to it. And if they do, there are, again, very rare cases where we will use a gold-plated device to get around the allergy. Most of what people think are an allergy when they see a reaction of the skin is more likely an infection. Charlie, have you ever seen a true allergy to a
I think one in 27 years, and they ended up with a gold-plated device, which is kind of stylish.
Okay, thank you. Regina asks, for either one of you, how often do you see SVC, stenosis, or syndrome related to leads, and what do you find are the best long-term options for these cases? Do you think a leadless system with pacing functionality will be available in the near future? Okay, Dr. Love?
Oh, I was going to try to have that too.
Yeah, I can start with it. Because I think we do see it more often in little kids because of the size of the vessel. So we see venous stenosis or obstruction pretty frequently. The smaller the patient, the smaller the veins, they're more likely, and the more leads that you put in, the more likely they are to get obstructed. And so to Dr. Love's point, abandoned leads are not a good idea. And so you don't want to have 4 or 5 leads through a vein, because then it is going to get stenotic or obstructed. And you did answer your own question. I think leadless pacing in the future will take away the issue of venous obstruction.
And so dovetail into that with younger populations, especially the ability to utilize the subcutaneous ICD that's not transvenous as a first choice is really a great one. And there's some new technologies coming out to make them even better. But anytime I see younger patients, especially our hypertrophs, mouthpiece, people like that, this is a great choice for these people to keep the wires out of the circulation. So if you get an infection, you don't get those vegetations inside the heart, all that. Wire fractures, although it's just an alert recall on the subcutaneous ICD wire, it is still, even with this recall on it, it is still the most reliable wire in the industry. So I don't get too crazy about that. But these leadless systems are useful. If you do get SVC syndrome, one of the things you want to be careful of is that your physicians don't put a stent in while you still have the wires there. What we like to do is go through, extract the wires, and I'll leave them, now that we've got guiding wires from extracting the pacemaker wire through the guiding wire in there. And then the interventional radiologist can deploy a stent and open up that vein cavity. So that is very doable. We've done that numerous times for people with CCC.
Okay, thank you. Considering the risk of infection with pocket manipulation, why isn't there a way to recharge the ICD battery either remotely or by a small incision to connect a cable?
So cool question, because the very first pacemaker implanted in 1958 was a rechargeable pacemaker. It was it had a nickel cadmium battery in it, and it was rechargeable. Then, as battery technology got better, rechargeables became more of a hassle and not so great. It used to be a really good pacemaker that you just would wear a vest, and the vest had a coil in it that would lay right over the pacemaker, and it would do what we call inductively coupled, just like your cell phone. When you put it on the mat, charge it. That's how it worked, and it would recharge the device. You do it every week, once a week, stick it with your vest on for a couple hours, and recharge your pacemaker. But once batteries got to last beyond a year or two, now we have pacemaker batteries lasting, defibrillator batteries lasting 10, 14, 15 years. It became less of an issue. So there are some interesting devices out there that are rechargeable. The other issue with defibrillators especially is that batteries have to be able to deliver a lot of current really, really fast. And most rechargeable chemistries can't do that very well. And what happens if the battery melts down when you try to pull all that current out? Remember, it's about a 3.5 volt battery in an ICD. It has to charge to 800 volts and 20 amps in 10 seconds. You pull a lot of energy out of that battery, and most rechargeable chemistries simply can't support that kind of thing.
Right. The other thing is, think about your laptop. You're not going to want to have your old laptop after 8 to 10 years. You're going to want a new one. So it's not just the battery you're replacing the whole generator that includes the integrated circuit, the computer chip, and all the other technology that really becomes obsolete. And so that's another reason why people got a little less enthusiastic about devices that last more than 10 or 12 years. There used to be a nuclear pacemaker that lasted 80 years, but nobody wanted it.
One final thing too is that even rechargeable batteries, as you know, your phone after 2 or 3 years, it doesn't hold the charge so well anymore. Your computer battery, whatever you've got rechargeable. Rechargeables do have a finite life as well. So I think industry has done a phenomenal job of developing battery chemistries that can last 10 to 15 years now and provide the kind of therapy, life-saving therapy consistently with that group.
Okay, thank you. So Felicia asks, what movements or exercises should be avoided? Should repetitive arm exercises be avoided? And can you be specific as to lifting arms overhead or any other arm exercises, and how much weight is okay?
Well, I'm gonna say, ask your own physician for personal specific guidance. But in general, I think, the first month after implant, we have more restrictions and don't lift your arm over your head. After that, my recommendation is, again, most of my patients are young. When Dr. Love says young, he means 55. When I mean young, I mean 5. And so there's a little bit of a difference. But I try to discourage them from gymnastics where they're hanging from the arm where the device is, supporting all their weight from that arm, or pull up type of things with rings. But in general, I let people play golf and swim and other repetitive motions of the arm. I think you want to live your life and understand that there may be more wear and tear on the lead, but there's a lot of downsides with exercise restriction and being a couch potato as well.
Entirely with that line of thinking. We can replace wires need be, and life is meant to be lived. And like I said, wires are like coat hangers. You bend and bend them. One day they're going to break. Even the best wires are going to fail after some period of time. And you put more stress on it, sure, it's going to fail sooner rather than later. But there's so many different factors that apply to why and when a wire will break. A lot of it has to do with how it's implanted. And industry continues to work harder and harder to make wires that will last longer and longer. And some of their efforts have been good and some not so good. Any of you ever had this wire called the Fidelis wire or Brugada wire? Those wires have terrible failures. And yet they put those wires through every torture test that they knew before they put them on the market. And then, once you put it into a doctor's hands, they implant it a certain way, and then put it into a patient with a hostile environment, body, and all emotions. As much as they try to mimic these things in the lab and production facilities, it's nothing like putting it into a person. So you test these things, and you put them into a couple 100,000 people, and all of a sudden you start seeing failures. You never knew that a wire could fail that way, so you never designed a test to look for that kind of failure. So every time they find a new kind of failure, they devise a new test to look for that kind of failure as they devise who leads. But it's hard to devise a test for a mode of failure that you don't know exists.
Thank you. Jeannie asks, if an ICD and leads are removed due to infection, is a new one put in? Do you wait until the infection clears up and then reimplant?
That's a really good question. If it's in your bloodstream, you need to wait a significant period of time, because you don't want to put a new set of wires into the bloodstream while you've got infection going there. That's a really bad idea. If it's in the pocket, and even if it's not, we've got it to one side, we generally will go to the other side or consider a subcutaneous ICD if that wasn't the kind you had. Unfortunately, with subcutaneous ICDs, if that pocket gets infected, there's nowhere else to put it. For a transvenous ICD, if it's on one side, you can move it to the other side. It's not as big of a deal. But for right now, we can only go to the single side of subcutaneous ICD. So if it's a pocket infection, we like to wait at least 72 hours before placing a new one, and in those circumstances, to make sure we didn't stir up the honeypot bacteria in the bloodstream when we do the extraction. For a infection in the bloodstream, we may wait several weeks. And now, of course, we have a wearable ICD. It's called a light vest. So we can safely send a patient home wearing this wearable, it's an ECD, external. It's a wearable defibrillator you can take home to protect you during that transition period between the extraction of the affected system and the implant.
So we have a 57-year-old who has one MRI safe lead, asked if he should consider extracting the other lead and replacing with the MRI safe lead and device.
What's that, Joe?
Pardon
I think that all leads are, well, MRIs can be done on leads and devices that aren't labeled as MRI conditional in the right center that knows how to do programming. Dr. Love's center was one of the leaders in doing MRIs on patients with ICDs even before they became MRI conditional. So I wouldn't necessarily take the lead out just so you can get an MRI. But if it's an abandoned lead or a non-functional lead, that's a different story.
So I would agree entirely with what you just said. I would not have a special operation just to replace that wire, because remember, every time you go into that pocket, you take that incrementally higher risk of developing infection. However, if you are going into the pocket anyway, another wire gets broken, your battery needs to be replaced. One would have that discussion with the physician at that point in time, whether the risk of replacing the non-MRI conditional wire and the greater availability of an MRI at a non-specialized center is worth the risk of extracting. So when we talk about extraction, we talk about a risk. Okay? There's a risk to taking things out, there's a risk to leaving things out. And that risk is individualized for every patient in every situation. So those are the kind of discussions you should have with the physician and potentially with someone who does the extraction.
Okay, thank you. Pat asks, is there an issue getting a mammogram?
No, that's an easy one. No, and there was somebody who said something about breast pumps, and that's not
Yes.
a concern either.
Okay, thank you. How many extractions are considered a lot? If I need to find a physician to extract a lead, how much experience should they have?
So the data suggests that if you're doing probably more than 60 a year, you're considered a higher volume extraction. think that's not a bad number. There's no, you know, if you do 59, you're not good, and if you're 60, you are good. It's obviously scales are great, and there are people that do a lot of things and aren't very good at it. People do very few things and are excellent at it. And by and large, volume makes you good at what you do. So the more practice you get, the better you are. And I think 60 is not an unreasonable number. Again, you could be at a center that does 60 with 8 doctors doing it, and each one of them does 80 years or something. So you've got to look for not only a center that does a lot, but also physicians that have that experience. It's a team sport. Everybody in the room has to know what they're doing, be ready for everything. And it's not just the doctor, it's the whole team.
Okay, thank you. Dr. Lead, Soren asks or comments, I'm a JH patient, I guess Johns Hopkins, right? And have an abandoned Sprint Fidelis fractured lead placed in 2006. My first device and current one are Medtronic. Do you recommend sticking with Medtronic device and leaving the newer lead 2011 pending integrity check?
So really good question. Right now, again, I wouldn't recommend going in and removing Fidelis. It depends on how old you are, whether you consider taking it out at the time it's generally changed. All manufacturers make really good stuff. Every now and then, bad player gets out there. Fidelis was one of the most. If you have another type of Medtronic leading right now, it's probably very, most of the Fidelises were replaced or a new one was put in called Quattro. It's reliable. It's all the same in the industry. So I wouldn't say going to company B, because company B is probably also had some wire issues or a battery issue. We all live in glass houses, so none of them those things, because every one of them has had some type of the decision to remove that the Fidelis, and at that point, that's a decision that should be made at the time to change. One other thing that you bring up that's sort of in that question is, you're getting the battery changed and your wire is 10 years old. Should you get the wire replaced at the same time you get your device changed? Because it's going to be easier and safer to take it out today than it will be 10 years from now. And that's a really tough question, because you take a risk of extracting it now, you take a bigger risk of extracting it. And we've actually done some studies done to look at randomizing whether you should prophylactically replace leads when you replace devices versus just waiting till the lead gets. The lead could last another 20 years or could last another 20 days. We just don't know. And it's kind of a push. The risks and benefits really fall down on both sides of the line. So generally, if I've got a patient with a wire that I think is a reliable wire that's working well, I can't guarantee it's going to work the next week, but I can't tell you it's not going to last another 10 years.
Okay, thank you. Let's see, Valerie asks, are there special considerations if someone also has a Marfan's related CTD?
Connective tissue disorder.
Thank you. All right.
For extraction or for device implants, or
It just says any special considerations.
Maybe
device
for
implants?
extraction, right?
Yeah, for extraction, not really. I mean, we deal with all comers. I'm not aware that particular group of patients has any greater risk. Charlie, are there any issues with regards to implant in these patients?
No, I think the one issue in the kids that are still growing with Marfan's, obviously they're
Oh, she
anticipated
says
to be,
for implants.
yeah, so they're anticipated to be tall, and so you need to make sure there's enough slack in the lead when implanting in someone who's not fully grown yet. That would be the main thing. But you have to remember in Marfan's, it's issues are in the arterial side, and the leads are going in the venous side. So that's just the main issue is anticipated growth of the patient.
Are there any additional healing issues that you're aware of with people with connective tissue disease?
Sometimes some of the patients that are on certain medications that may inhibit healing might be the only issues, like Remicade or something like that.
Okay, thank you. How long do leads typically last for ICDs?
With my crystal ball at the office, so I can't tell you. I've seen leads last a year and I've seen leads last 35 years. It depends on the lead, how it's put in, the activities of the patient, so many different kinds of factors that are. So it's, batteries, we interrogate the device and it says we got 7 years left. And unless you've got a defect in the battery or something, it's going to last 7 years. The pacemaker wire, I can test it today. It's great. And tomorrow night, if the alert goes off, the there's been a fraction of a dollar. Which again brings to the point that remote monitoring is so important for all of our patients, that you do it, you keep connected, and if you sense an alert, some devices vibrate, some beep, some just transmit to the bedside monitor. If it alerts or beeps, we can get that information that day, that night, without you running into the ER, say, oh, the batteries are replacement time, or we got a wire break, we need to get in right now. Really, really important.
All right, I see that. Oh, one more question. No, thank you very, very much for both. Several have commented. They really appreciate all the information and keeping people up to date. So I appreciate your PowerPoint presentations, and as well as addressing all these questions. It's been very helpful. And I wanted to remind everyone, as Alice pointed out in the chat session, we have a webinar next week on ICDs, patient experiences, patient perspectives, same time next Wednesday night. And Dr. Berul will be available in case there's any medical type questions, but stay tuned for that as well. So I thank you very much, Dr. Love and Dr. Berul. I appreciate your presentations and appreciate your time tonight. So thank you, everyone. Have a pleasant evening.
You're well, everybody, and thanks for watching this evening.
Thank you.
All right. Good night.